Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
It's my great honor to welcome you to this session on precisely oncology in HER2 mutation non-small cell lung cancer. Today, we gathered here to explore one of the most fascinating yet challenging frontiers in therapeutic oncology. The evolving landscape of HER2 mutation in non-small cell lung cancer and the implication of diagnosis, treatment, and patient outcomes. HER2 mutation, right now we know, is 2% of non-small cell lung cancers. Represent a clinical subsets where targeted therapies are resemblance thoracic oncology. Unlike HER2 application in breast cancer or gastric cancer, we know HER2 mutation non-small cell cancer express the distinct biological behavior and response to treatment necrosis. Here, today, we just focused on the precision oncology in HER2 mutated oncology, non-small cell lung cancer. It's my great pleasure here. My name is Yong Fang. I come from Department of Medical Oncology, the Ronald Shaw Hospital, Zhejiang University School of Medicine, Hangzhou, China. Also, it's my great pleasure to introduce the two faculty. One is Hee-Lung Kim, is professor from Medical Oncology, Chief Lung Cancer Center, Division of Medical Oncology, Yongsan Cancer Center, Seoul, South Carolina. Welcome. Another faculty, Hibiki Udagawa, Professor Thoracic Medical Oncologist, Department of Thoracic Oncology, National Cancer Center, Hospital East, Kashiwa, Japan. Welcome. This slide shows the agenda of this session. Next, I will invite the faculty, Hibiki Udagawa, professor. Just he focused on the burden of the disease, understanding the patient experience. Welcome.
Thank you for your introduction, Dr. Hang. So, good afternoon, everyone. I'm Hibiki Udagawa from National Cancer Center, Hospital East. Yeah, so it's a great honor for me to be here and give a presentation here. So I would appreciate if you enjoy this session. So first, I'd like to talk about understanding the burden of disease. So lung cancer was a leading malignancy worldwide, and Asia represents the highest burden of disease in lung cancer. And East Asia contributes a half of new cases. And this table shows the incidence rate of HER2 mutations in non-small cell lung cancer in the United States, Europe, China, Japan, and Korea. The incidence rate of HER2 mutations in non-small cell lung cancer in the United States and Europe are 1% to 3%. And in Asian countries, the incidence rate of HER2 mutation are 1.4% to 6.7%. So unlike EGFR mutations, there are no big difference between the United States and Europe and Asian countries. Next, I'd like to talk about HER2-mutated non-small cell lung cancer as a distinct molecular subtype. So this graph shows the mutational landscape for non-small cell lung cancer in early stage and metastatic stage in the United States. As you know, in the United States, the most common genetic alteration is KRAS mutations, and the second was EGFR mutations. And ERBB2 is a HER2. So HER2 mutation, ERBB2 mutation occur in 1.8% of early stage and 3.8% in metastatic stage. And also, so ERBB2, HER2 gene amplification occurs in 1.6% in early stage and 2.7% in metastatic stage. Today, we'd like to talk about ERBB2 HER2 mutation mainly, not ERBB2 genetic gene amplification. This figure shows the frequency of HER2 mutations in various types of cancers, such as bladder, stomach, breast, and non-small cell lung cancer. So in this study, the frequency of HER2 mutation in non-small cell lung cancer was around 3%. And HER2 mutation variants vary across different cancer types. In non-small cell lung cancer, a half of HER2 mutation exon 20 insertions mutations. The most common HER2 mutation in non-small cell lung cancer is Y772 duplication, YVMA. On the other hand, in breast cancer and colorectal cancer, HER2 exon 20 insertions was not detected, just only point mutations. So there are a big difference, but we don't know why. This table shows the clinical characteristics of Chinese patients with non-small cell lung cancer harboring HER2 mutations. In this cohort, the median age was 54 years old, and 65% was female, and 80% was never smokers. And almost all had adenocarcinoma. Next, I'd like to talk about current guideline recommendations and the standard of care for patients with non-small cell lung cancer harboring HER2 mutations. This is from NCCN guidelines. In the first line, systemic therapy, platinum-based chemotherapy with or without ICI is recommended. This is from ESMO guideline. In the first line, platinum-based chemotherapy with or without ICI is recommended. And in the second line, only trastuzumab deruxtecan is recommended. So zongertinib and HER2 TKIs are not recommended just now, but I think HER2 TKIs will be recommended in near future. This is a guideline from Japan Lung Cancer Society. In the first line, so as well as NCCN guideline and ESMO guideline, in the first line, platinum-based chemotherapy with or without ICI is recommended. And in the second line, trastuzumab deruxtecan and zongertinib are recommended. So next, I'd like to talk about unmet needs in HER2-mutated non-small cell lung cancer. Where now and where next? So I'd like to introduce this paper from our group. So efficacy of ICI plus platinum-based chemotherapy as first-line treatment for patients with non-small cell lung cancer harboring HER2 mutations, result from LC-SCRAM Asia. So LC-SCRAM Asia is a nationwide genomic screening project to identify lung cancer patients with genetic alterations and to establish and develop a novel precision oncology for them. Until now, 3,050 institutions in Japan and 25 institutions in in these Asian 6 countries have participated in LC Scrum Asia. So I'd like to say thank you for every participant. This figure shows the frequency of detected oncogenic drivers in Japanese patients in LC Scrum Asia. The frequency of HER2 ERBB2 mutation was around 3%. So EGFR and KRAS and BRAF mutations and ROS1, RET, ARC, NRG1, NTRK fusions are also detected in LC Scrum Asia. So this figure shows the subtypes of HER2 mutation detected in LC Scrum Asia. So HER2 mutation on tyrosine kinase domain and extracellular domain are detected. And in all HER2 mutations, 80% was exon 20 insertions mutations. And in patients with HER2 exon 20 insertions, the median age was 65-year-old, and half of them were female, and half of them were never smoker. And almost all had adenocarcinoma. And in HER2 exon 20 insertions, 60% was YVMA duplication. This is the most common HER2 mutation in non-small cell lung cancer. And in patients with YVMA duplication, the median age was 67-year-old, and half of them are female, and half of them are never smoker, and almost all had adenocarcinoma. And these are Kaplan-Meier curves, survival curves of patients treated with platinum-based chemotherapy alone or platinum-based chemotherapy with ICI as first-line treatment. The left one is HER2 mutations, all HER2 mutations, and right one is YVMA insertion duplications. So red curves are patients treated with platinum-based chemotherapy with ICI, and blue curves are without ICI. In HER2 mutation and in YVMA duplication, the patient treated with platinum-based chemotherapy with ICI as first-line treatment showed longer PFS and OS compared with the patient treated with platinum-based chemotherapy alone. And German retrospective analysis of first-line ICI chemotherapy, the ORR was 52%, and the median PFS was 6 months. In a Polish retrospective analysis, the ORR was around 30%, and the median PFS was 5 months. This figure shows the efficacy of ICI monotherapy. This survival curve is from our study. So ICI monotherapy, the efficacy is limited. So the median PFS was 2.2 months and the DOR was 0%. And these results were consistent with previous studies. So as I showed, platinum-based chemotherapy alone, platinum-based chemotherapy with ICI, and ICI monotherapy, the efficacy, this efficacy was limited. So we need more better and more strong, more effective targeted therapy is needed. So we need them. So these are targeted therapy for HER2-mutated non-small cell lung cancer, already approved and under development. So trastuzumab deruxtecan is a HER2 ADC, and zongertinib is an oral HER2 specific TKI, and selvatinib is an oral inhibitor of HER2 and EGFR. So Dr. Kim will talk about them. And this is my final slide. So in patients with advanced non-small cell lung cancer, the burden of disease is significant. So adapting to life with lung cancer and the holistic support of patients throughout their journey is very, very important. So we would like to discuss about them after this presentation. And we would like to show a video about Mr. Kong and his journey.
My wife was asking me, why you like to do gardening? I said, I don't know why. I'm alone and in the garden. I feel so happy, and then I feel that everything is so, you can see this, I can feel that all my body is so relaxed when I do gardening. The oncologist explained to me that the kind of cancer I have is lung cancer, stage 4 lung cancer. And he told me that I was given 5 years to live. So, of course, 5 years is quite shocking to me. And the people I worry around is those people around me, so my wife and my children, they are still dependent on me. My daily life changed, of course, it changed drastic because literally I can't do the thing that I used to do. So most of the time I will sit down and just, even eating also is a nightmare to me. The moment I eat something, a short while later I have to throw out most of it. And I drink water, I can't drink the kind of room temperature water. I will drink warm water, and I go to sip it. I can't drink it just as normally what I do. I do a lot of soul searching. I have self-reflection. For medical wise, I leave it to the doctor. I have full time as a doctor, and he is very knowledgeable and very passionate in his work. And I can see that he did explain to me my condition. So I have full confidence in him. I leave it to him to take care of my medical needs. And on my side, I do what I need to do. I treasure every moment, take life easy, and think positively and do positive things so that you give me positive energy. I think that this support group is very useful and very helpful for cancer patients, because a lot of cancer patients, when they are in the beginning, when they are diagnosed with cancer, they will get lost, and then they don't know who to approach. Some of them, they may have a lot of anxiety, and some they are so worried until they have depression and all this. So it's good that they come together and share their experience and encourage each other, give moral support to each other. That would be very good. Yes.
Okay, thank you, Professor Udagawa. He gave us a topic about the burden of the disease, understanding the patient experience. Here, I will focus on the HER2 in non-small cell cancer. How to test the HER2 mutation. Okay, we can see the slide shows the difference in HER2 alteration in non-small cell lung cancer. We know HER2 alteration in non-small cell lung cancer includes 3 types: gene mutation, gene amplification, and protein overexpression. We know HER2 gene amplification is almost 3%, and the HER2 protein overexpression is a major from 2 to 38% detection by the immunohistochemistry. But HER2 gene mutation, just only 4%. It's detection by the NGS or RT-PCR. Also, we can see overlap among these alterations is rare. So each alteration leads to the distinct biological behavior, affect different patient subset and the response to anti-HER2 agents. Right now we know HER2 ADC and the HER2 TKI is sensitive to the HER2 gene mutation. This slide shows the overview of HER2 structure and the signaling. We know HER2 is a receptor tyrosine kinase. It's just that we know EGFR, HER1, HER2, HER3, HER4. It's a big family. But HER2, we know activation can induce the hormone and the heterodimization and the downstream activation of a cellular pathway. Also, we can see alteration in HER2 pathway can drive oncogenesis by increased dimerization and autophosphorylation, leading to the uncontrolled cell growth. So HER2 mutation, according to the clinical information, it also grows quickly. This slide shows the HER2 mutation, the landscape in non-small cell lung cancer. Just now, we talked about almost 2% to 4% of patients with non-small cell lung cancer have the HER2 activated mutation. HER2 tyrosine kinase domain mutation are the most common, especially with the Y772 to A775 duplication. This happened on the exon 20 inserts. So we know three main subtypes of activating EGFR HER2 mutation, especially exon 20 insertions. It's almost 50% to 60%. And also we can see transbrain domain mutation. It's happened 10% to 20%. And the last is extracellular domain mutation. It's happened 20% from 10% to 20%. Also, this slide shows the biomarker testing gaps and the clinical implication in advanced non-small cell lung cancer. This shows, based on the retrospective study, linking the electronic medical records with genomic testing, only 50% of patients with the driver mutation are receiving guideline-aligned therapy. And we can see, for patients with a driver mutation, improved OS is observed among those treated with the guideline-aligned therapy. The median OS is 18.6 months. But those who are not guideline-aligned is only 11.4 months. Also, we know barriers to biomarker testing there are four unmet needs. First one is length turnaround times for NGS testing. In my hospital, we always spend 5 to 7 days to get the NGS result. For the RT-PCR, we always get 2 or 3 days to get the result. And the second is the availability of timely but less accurate single gene testing. 3 years ago, we always just detect EGFR, ALK, and ROS1. Till now, we always including at least 10 genes. And the third is insufficient number of quality tumor cells. The last is a lack of awareness of guidelines. So together, we just learned the information about the HER2 mutation, improved our knowledge to learn to know how HER2 mutation is detected. When do we test? According to the NCCN guideline, we can see for the advanced stage non-small cell lung cancer, when the patient diagnosed as the adenocarcinoma or large cell carcinoma, it's a reference to detect the NGS. It's including the EGFR, ALK, KRAS, ROS1, and including the HER2. But according to the ESMO guideline, we can see testing for the advanced non-squamous carcinoma. This is almost the same. So when do we test? NCCN guideline and the ESMO guideline told us advanced non-small cell lung cancer, including adenocarcinoma or large cell, can reference to detect NGS. The next question, how do we test? We can see NCCN and the ESMO have different guidelines. For the NCCN is issued recommendation for ERBB2 mutation While targeted PCR techniques and the surgeon sequence can be used, NGS-based approaches are the best and surviving the broad spectrum of genomic mutation. According to ISMO, the ISMO guideline reference, if available, NGS for molecular testing are preferable. So how do we test? We need to use the NGS or RT-PCR. This slide shows the techniques and the platforms for detecting the HER2 mutation, including the SENG, RT-PCR, FISH, immunohistochemistry, and NGS. So we can see NGS is strongly recommended. HER2 mutation are detected with NGS SENG sequence and the RT-PCR. But NGS is strongly recommended because it is always including at least 10 genes, including the EGFR OCLOS1 plus the HER2. So NGS is strong recommended. Let's go back to the EGFR TKI. We know after the patient takes the EGFR targeted therapy, we always know that the patient would be resistant to the target therapy. But for the targeted therapy, what can we do after resistant to the TKI? We know biopsy and retest. So we can see oncogene abnormalities related to resistant to the third generation EGFR TKI can include the drive genes abnormalities such as MET, HER2 amplification or mutation. So for the NCCN guideline, after the EGFR TKI resistant, we always suggest the patient go back and biopsy and get the NGS so we can find out what's the best way to control the resistance. Also, we can see co-occurring ERBB2 alteration in non-small cell lung cancer. Just now we talked about NGS is better at identifying the co-mutation populations which require combination therapy. But we can see different co-mutated genes between ERBB2 oncogene mutation and with ERBB2 amplification. TP53 EGFR and CDKN2A was significantly more frequently co-occurring with amplification. Also, we always observe the TP53. The right picture shows the survival of TP53 co-alteration. From the OS, the bar, we know that absence of TP53 is associated with favorable outcomes in subvertinib-treated HER2-mutated non-small cell lung cancer. This slide shows the algorithm for testing HER2 alteration in non-small cell lung cancer. Just now we talked about use the FISH, NGS, or ARMS PCR to detect the patient have the HER2 mutation. But if the following situation, we just test repeated, such as results are inconclusive. Initial sample quality is low. Plasma testing is negative, especially the patient have no history of smoking, close to a cutoff limit, and the normal mutation is found. So this 5 situation is a strong reference to detect again a biopsy or get the tissue sample. Also, HER2 mutation is a difference between Chinese and the Western population. This slide shows the difference. For Chinese patients, most frequent HER2 mutation were A775, G773 in YVMA, and the Y772, A775 duplicate. That's the more happening in Chinese patient. And also we can see HER2 kinase domain were most commonly mutated. Today, here with the ESMO issue, so the Chinese, the patient, the situation, I think information, I think maybe for the Japan, for the Korea, I don't know exactly the thing. Maybe we can discuss it later. And for Western, most frequent HER2 mutation was E401E, R2226R, then followed by G776D line. And also we observed foreign-like cystine Lynch region was the most common mutant, followed by HER2 kinase and the receptor L domain. This slide shows the Chinese expert consensus is the latest edition, diagnosis and the treatment of HER2 altered non-small cell lung cancer, especially focused on the 6th question issue. What are the main types of HER2 alteration in non-small cell cancer? What's the clinical significance of HER2 mutation status? What should the HER2 mutation be tested? How to select sample for testing, and recommend the testing methods. At last, how to interpret HER2 mutation test results. That's when you detect the HER2 mutation, what we can do, ADC or TKI. Also, we need to focus on the quality control in HER2 mutation testing. That's the sample selection and the precision method. As John referred to use the tumor tissue samples. Especially, we need to focus on tumor cell contents is more than 20% is recommended. If lower than 20%, I think I always ask the patient to rebiopsy or apply the fixation process. And then, if we couldn't get tumor tissue, we can select the cytology sample, such as sputum, fluid, and effusion. Sometimes we can EBUS. That's the cytological samples. If we couldn't get the tumor tissue or cytological samples, at last, we refer to liquid biopsy, such as blood ctDNA, or CSF supernatant. Also, we need to focus on quality control, sample selection, and the precision methods. At last, we get the NGS report. We know when we get the report, we need to focus on the 5 issues. The first is specimen details, including the sample type, percent tumor cells. If lower than 20%, you should think about the test is right or false. Assay details, biomarker finding, quality metrics, and recommended actions, especially what can we do? What can we, doctors suggestion? Also for the HER2 mutation, always we can suggest MDT. We know MDT is key for lung cancer decision making, always including the patient and their relative, pathologist, oncologist, and nurse. So we together discussed about the patient, the case. What can we do? What kind of methods we suggest to the patient? ADC or TKI or first line of chemotherapy plus the immunotherapy. Also, for the testing, we have some challenges and solutions. Just 4 challenges. And first, NGS is not currently covered by the national healthcare system in China. It's almost spend 5,000 yuan, RMB, most $700. So making it expensive for patients who must pay out of their pocket. And the second, many hospitals do not have their own in-house testing platforms. The third, improved HER2 mutation testing rates requires the testing should be performed before treatment and at progression on EGFR TKI. I think in the future, exploration of HER2 TKI resistant mechanisms in non-small cell lung cancer is warranted. Also, let's watch the video.
The oncologist told me that they need to test because he need to prescribe the right medication for me. So I have to go for the test, and then he was able to prescribe me with the right medication. And the process took about 1 week, and he came back with the medication for me to take. He told me that there is more medical treatment available compared to 10 years ago. I feel relieved, and then I said yes, I accept it, and then I leave it to him to take care of my medical plan. My trust to the medical team is there, so whatever he asked me to do, I'll just follow strictly, because so far they have not failed me. The medical words is quite difficult to understand for me as a layman. But if I want to ask in a simpler form, the doctor is willing to explain to me as a layman, where a layman can easily understand. Yeah, I have heard of people who went for second or third opinion when they see a doctor. But to me, if I find that this doctor can be trusted, I leave it to him. I don't get extra stress, and then I'm not getting a bargain. This is between life and death. He can do a good job. Leave it to him to do. And for my case, I have to do my part also in terms of spiritual, both in terms of my activity and also my mindset. So I find that these are the things that I can do it myself. I do it. For medical aspect, I will leave it to the doctor. Yeah.
Okay, next, I will invite Professor Hai-Ren Kim. He will focus on the targeting HER2 mutation in non-small cell lung cancer. Welcome.
Thank you for kind introduction, Chairman. Hello, everyone. I'm Hai-Ren Kim, the medical oncologist in Yonsei Cancer Center, Seoul, Korea. Thank you for inviting me to this precious symposium. Today, I'm going to talk about targeting HER2 mutations in non-small cell lung cancer. So, looking at this mechanism of action for ADC and TKI, so as you mentioned in the previous the speakers, the HER2 ADC is composed of 3 parts. And first is a HER2-directed monoclonal antibody, and second is linker. And the third is topoisomerase 1 inhibitor payload. Finally, ADC are targeted treatment that deliver the chemotherapy payload directly to the cancer cells through the linker attached to the monoclonal antibody. The tyrosine kinase inhibitors is essentially signal blockers that prevent the cancer cell from receiving growth signals. So looking at this sevabertinib, the sevabertinib is an oral reversible tyrosine kinase inhibitor targeting the HER2 activating mutation. So capable of inhibiting mutant HER2 receptors, including HER2 exon 20 insertion and HER2 point mutation and EGFR mutation as well. The selectivity for HER2 activation mutation over the wild-type EGFR. Recently, sevabertinib got the FDA accelerated approval currently. So next TKI is jongotinib. Jongotinib is an oral EGFR-sparing HER2-specific tyrosine kinase inhibitors. They selectively and covalently bind to the tyrosine kinase domain of both wild-type and mutated HER2 receptors, although sparing wild type EGFR, the wild type, the recently FDA accelerated approval. We have currently 3 options for HER2-mutated cancer: the T-DXd and zongertinib and the sevabertinib. So move on to the ADC data in the second-line setting and beyond, trastuzumab deruxtecan and trastuzumab risdiplam. Looking at this data and the DESTINY-Lung02 final analysis, the efficacy of T-DXd in HER2-mutated non-small cell lung cancer, regarding the confirmed objective response rate, the 2 different dose and 5.4 milligram per kg was approved, and 50% of patients objective response rate, and 53% of objective response rate in the higher dose. And duration of response is 12 months, and the median progression-free survival is 10 months and 12 months in the respectively, and overall survival 19 months and 17 months. Finally, the T-DXd showed durable anti-cancer efficacies at both doses, with confirmed objective response rate occurring in the more than 50% respectively. So how about the safety of T-DXd in HER2-mutated non-small cell lung cancer, the DESTINY-Lung02 data? Looking at this data, the most common grade 3 treatment emergent adverse event is GI toxicity or the hematologic toxicity. So I'd like to focus on the adjudicated drug-related ILD in the trastuzumab deruxtecan. Any grade of the ILD is 14%, in the lower dose 5.4 milligram per kg. However, in the 6.4 milligram kg higher dose, the any grade ILD is 32%. So most of grade 1 or 2, however, this is a very fatal event in the HER2 the mutated patients. Overall, the approved dose is 5.4 milligram per kg, show more favorable benefit and risk profile and lower incidence of ILD or pneumonitis when observed with longer the follow-up duration. This is the pooled analysis data, DESTINY-Lung01 and 02 intracranial activity. So, as you know, in the HER2-mutated patients have high risk of brain metastasis in those patients. So brain control is very important. Intracranial, the objective response rate is 50% in the lower dose and the 30% in the higher dose. However, the number is very limited, and we should keep in mind more the interpretation is more cautiously. Intracranial disease control rate is 90% and the 70%. The brain lesion size reduction in the almost 90% of patients with measurable brain metastasis receiving the T-DXd 5.4 milligram per kg, and 80% in the pooled 6.4 milligram per kg. So finally, T-DXd is approved for advanced non-small cell lung cancer. The FDA, the T-DXd lower dose 5.4 indicated for the unresectable or metastatic non-small cell lung cancer with activating HER2 mutation after prior platinum-based chemotherapy, and the HER2 positive overexpressions IHC3 positive solid tumor was also approved. This is another cancer type specific. It's just a tissue agnostic approval. How about the Asian? T-DXd is approved in Korea, Japan, and China for the treatment of adult patients with unresectable or advanced HER2-mutated non-small cell lung cancer and prior treated with the systemic treatment. Looking at the trastuzumab risdiplam in HER2-mutated non-small cell lung cancer, the in Horizon the lung trial. This is a single-arm phase 2 trial conducted in the China only to evaluate trastuzumab risdiplam in the patient with HER2-mutated advanced non-small cell lung cancer with disease progression on the prior treatment. In the patient, 94 patients, The 73 patients had confirmed objective response rate. It is good response. And progression-free survival is 11.5 months, and the median overall survival is currently not reached. How about the safety? The most common grade 3-4 AE is hematologic toxicity, and other toxicity is most grade 1 or 2. And how about the interstitial lung disease? And grade 1 or 2 is 6% was observed, and the grade 3 is 1%. So move on to the novel TKI for HER2-mutated non-small cell lung cancer. So I'd briefly show the sevabertinib and the jongotinib. The sevabertinib in the HER2 mutant non-small cell lung cancer, the SOHO-01 trial, they're looking at focusing on the code DEF, and the D is previously treated but naive to HER2 targeted treatment, and the code E is previously treated with HER2 targeted ADC, and the F code is naive to systemic treatment for advanced disease. So primary endpoint is extension phase is objective response rate by Bigger, and the secondary endpoint is DOR and the DCR, PFS, or and so forth. They're looking at this data, the code D, and the previously treated, however, naive to HER2 targeted treatment, objective response is as much as 64%, and duration of response 9.2 months. The code E is previously treated with HER2 targeted ADC, and the overall survival is the 38% less than code D, the result. Duration of response is 8.5 months. They're looking at this code D data, they're focusing on just patient with non-squamous non-small cell lung cancer and HER2 tyrosine kinase domain mutation, and the enrichment objective response rate at 70%. So the code E, the objective response rate is almost 40%, and F, the treatment naive patient is objective response rate is almost 70%, and the progression-free survival is not evaluable yet, and the median duration of response is 11 months. So to recap, the sevabertinib showed anti-tumor activity in the patient with HER2-mutated advanced non-small cell lung cancer, and they're both pre-treated and the first-line setting. How about the safety? Some sevabertinib in SOHO-1 trial, they're looking at this pooled analysis data in the DEF, and the treatment-related adverse event, and the grade 3 event is almost the 90% or 100%. The more in detail, the most common AE is diarrhea and rash and paronychia. This is some kind of the EGFR blocking the class effect, and the diarrhea is code D is the 87%. However, some the grade 3, more than grade 3 is 14%, and the rash is the 50%. However, grade 3 is 1%. So comparing to the TDXD, there was no cases of ILD in the sevabertinib. However, we're looking at the intracranial activity. So in patients who did not have a baseline, the brain metastasis, the less than 5% developed a new region in the brain as a progression site. This is a kind of the brain protection, the activity of the sevabertinib. How about the factors impacting the clinical outcomes with sevabertinib? In terms of molecular characteristics, P53 and HER2 YVMA, this is a very frequently occurred TKD mutation, provide independent prognostic information. Looking at this PFS survival curve, the patient with the harboring YVMA mutation have good, favorable response prognosis compared to others. And how about the TP53? And the patient with TP53 mutation show poor prognosis than the without TP53 mutation. So sevabartinib in the HER2-mutated advanced cancers, in these asthma meetings, there are some updated in the ASEAN population. So safety and treatment-related adverse event is almost similar in the global data. Some diarrhea was most common event in the sevabartinib treatment, and grade 1 or 2 is 76%, and grade 3 is the 11%. There was no reduction, some kind of the treatment-related adverse event leading to the dose reduction in the 27 patients, and discontinuation is 3. There was no ILD even in the Asian population. How about the efficacies? So objective response rate 60% in cohort D, and the cohort E is 46%, and the cohort F is 66%. So this is a very comparable data with the global the study. Moving on to the jongotinib, in BEAMING-1 some lung 1 trial, and the cohort 1 of BEAMING-1 lung 1 trial is to evaluate the jongotinib in the pre-treatment the non-small cell lung cancer with the HER2 TKD mutation. This is not included in the point mutation, just focusing on the TKD mutation. The 120 milligram was selected at interim analysis. Primary endpoint is objective response rate. Looking at this data, the objective response rate is 70%, and this is control rate is almost 100%, and the progression-free survival is 12 months. The jongotinib show clinical activities in the patient with previously treated HER2-mutated advanced non-small cell lung cancer, especially in the TKD mutation patient. How about the safety? The safety profile itself is very similar with the sevabartinib. However, the percentage seems to be lower than the sevabartinib. The diarrhea is 53, almost 60% have diarrhea in any grade, and more than grade 3 is 8%. And also, there was no issue about the ILD in the jongotinib. Regarding the tolerability, the dose reduction was 7%, and discontinuation due to the toxicity is 3%. So intracranial activity, the food analysis cohort 1 and 4, the intracranial activity is some objective response rate is 40%, and in the patients focusing on the no prior brain radio treatment is 44%. And median progression-free survival in the brain metastasis is 8%. So jongotinib show the intracranial objective response rate of 44% in patients without prior brain radio treatment, and overall reduction of brain lesion size in the almost 95%, showing good intracranial response. So how about the East Asian population? Also, jongotinib data was updated in the ESMO Asian, updated in the Asian population. Regarding the objective response rate, in the cohort 1 East Asian population, objective response rate is 76, and the Chinese patients, 80% have objective response rate. And regarding the safety issue, the treatment-related AE in East Asian population is all grade 92%, and more than grade 3 is 18%. Also, the diarrhea was most common, and most is grade 1 or 2. So from now, and I will briefly about the emerging frontline development, the sevabartinib in HER2-mutated non-small cell lung cancer in the cohort F is treatment-naive patient, is a first-line patient. Looking at this data, in the frontline treatment with sevabartinib show comparable objective response rate, the 60% to the pre-treated cohort. However, it is just ongoing trial and immature data, and we need to the more follow-up. Regarding the safety issue, and grade 3 just 1, and no cases in the ILD and the pneumonitis. And currently, SOHO 02 data is currently ongoing. This is a randomized trial, phase 3, evaluating sevabertinib versus standard of care, the chemotherapy agent combined with immunotherapy as first line, the locally advanced metastatic harboring HER2 activating mutation. Primary endpoint is PFS by BICR. Secondary endpoint is overall survival or and so forth. So jongotinib, the first-line treatment in BEAMING-ON lung trial. So phase 1b, cohort 2 is treatment-naive patient, non-small cell lung cancer, HER2 TKD mutation. The primary endpoint is objective response rate. Looking at this data, the objective response rate is 77%, the 6 months duration of response is 80%, and the PFS is also 75%. And regarding the grade, it is very similar and consistent and diarrhea, and the rash is most common. There was no issues in the pneumonitis so far. The frontline treatment with jongotinib show clinically meaningful benefit in the patient with regardless of HER2 mutation type. However, it just focuses on the TKD mutation. So currently, the beaming on the lung 2 is currently ongoing. This is a randomized phase 3 data evaluating the jongotinib versus standard of care. The jongotinib, the 120 milligram once daily, and there's some 165 patients and each arm. Primary endpoint is progression-free survival. And the secondary endpoint is objective response rate or overall survival. So another TDXD is also primary the first line treatment. The Destiny Lung 04 is randomized trial, and the TDXD comparing standard of care, very similar design in the prior to TKI. The non-small cell lung cancer HER2 exon 19 or 20 mutation by tissue NGS or ctDNA. It just not focusing on the just HER2 20 mutation, also including HER2 19 or some 20 mutation. The primary endpoint is PFS by BICR, and the secondary endpoint is overall survival. This is almost a final slide, and the future directions. As you shown in this prior slide, so moving toward to the front line, and maybe that in the near futures, engagement in the operable setting, that we know about that the similar pattern in the EGFR mutant or ALK or and so forth. And to improve the survival outcome, I think the more potent anti-HER2 inhibitor need to be developed and to mitigate the toxicity and to improve the survival outcomes. And the combination strategies with immunotherapy or some another anti-angiogenic agent are currently underway. We need to wait the data. And how about the CNS activity and the optimized toxicity profile is important things. And finally, and the biomarker-driven treatment using ctDNA, HER2 mutation subtype, and the HER2 amplification over expression and co-mutation, the refined patient selection are needed. So I'd like to share my patients' cases to discuss in this session. So first cases is a 74 years old the woman with never smoker, and this patient diagnosis with stage 4 adenocarcinoma without the actionable mutation EGFR ALK loss or wild type, and the PD-L1 expression is 10% at the baseline. We treat the patient with the first line immunotherapy combined with chemotherapeutic agents on the July 2021 to the April 2023. So enrolled in the clinical trial. Luckily, this patient best response is a partial response in this patient. So during the first treatment, I performed the NGS testing using the tissue sample, the platform TSO 500 2022, and this patient showed HER2 exon 20 insertion mutation, YVMA mutation type, and concurrently, this patient have TP53 mutation, missense mutation. So in our centers, and we are clinical trial about some SOHO 01 trial at the time. So as a second-line treatment, May 2023, and we tried to enroll this patient in this clinical trial, the sevabertinib. So we started May 2023. So looking at this patient imaging, so baseline, this patient have multiple pleural region and the right upper lobe and the left upper lobe region with the pleural setting. So after 2 months of sevabertinib, this patient showed a partial response, some almost 40% of the tumor burden reductions, even after the 2 months, marked decrease of tumor region. And they're maintaining their partial response at the time of that after 15 months since the first dose. However, unfortunately, this patient have disease progression after 18 months, and also this patient have newly developed on the abdominal lymph node. So, we try to do the regimen changes at this point. So as a third line, this patient is a HER2-mutated patient. The only approvable regimen at this point is TDXD. So we started TDXD on the December 2024. Duration is not much longer, and just 8 or 9 months, this patient maintaining with TDXD. However, this patient partial response at this the first time. However, this patient have finally disease progressions during the 8 or 9 months. So I'd like to share the second patient. So 63 years old female patient, the lung adenocarcinoma stage 4. As shown in this PET scan, this patient have very extensive bone metastasis accompanied with liver metastasis and lung metastasis and so forth. So this patient, I think that this patient have very aggressive features and rapid progression. So we try to do the NGS testing at the baseline using the liquid box and Guardant panel. So I think that I try to do that because the very active TAT, just 5 or 7 days in the liquid biopsy, that this is very faster result compared to tissue biopsy. So this patient have a HER2 exon 20 insertion mutation. So, and also this patient have a HER2 amplification. So we enrolled this patient in the clinical trial, another HER2 targeted TKI. The best response is luckily partial response in this patient. So we started this patient treatment TKI from the March in this year to the current. Looking at this slide, so in the left circle, there are huge mass on the mediastinum and the parabronchial region and the liver metastasis like that. This is a target lesion. So after the 2 months, there is very remarkable and tumor shrinkage at this moment. And after 4 months and after recently the latest CT scan, there was no very tiny lesion was still remaining. We need to follow more and maintaining this HER2 TKI. So this is my sharing the cases. And I'd like to ask some questions, the guys. And I think there's some expert in this field, Dr. Pang and Dr. Udagawa. So I'd like to some the questions. How should the HER2 therapies be sequenced, and what are the considerations choosing the ADC or some TKI? My question is ADC first and the TKI, and the TKI first ADC. So maybe could you answer this question?
Okay, you first.
Okay. Yeah, this is very difficult question just now. So we need to wait the result of the phase 3 study of 3 drugs. But just now, so I would like to use TKIs as early as possible because I have several reasons for this. So first one is the efficacy of HER2 TKI is better in a HER2 target therapy naive patient compared with previously HER2-targeted treated patient. And in preclinical study showed that, the use of HER2 ADC lead to resistance to HER2 TKI, but there are no detailed mechanism. But yeah, use of HER2 ADC lead to HER2 TKI resistance. So I would like to select HER2 TKI. And in addition to that, so we have so much experience of EGFR TKI treatment in HER2-mutated non-small cell lung cancer patients. So yeah, it is easy to manage adverse event by HER2 TKI for us.
Okay.
Okay.
Yeah, TKI first, and
Yeah,
then
TKI
the ADC is preferred options in the
Yeah.
Utagawa. How about the Pan?
According to my opinion, I just focused on three. First is safety. If the patient has a diagnosed as ILD first, because most of the lung cancer patients have the pneumonia or other chronic lung disease, I will select the patient to select the TKI. That's the safety. And effective, from the effective, we know right now ADC, the OR is lower than the TKI. It's almost the OR is for ADC is about 50%, but the TKI is almost OR is 70%. So effective ADC is lower than TKI.
Yeah, so thank you for your answer. So I think there's some, we need to follow up the data and the first line ADC or the first line TKI, the currently ongoing data could be answer for this question.
Yeah.
So, so I'd like to some second question. So, as I mentioned, there are some the managing the safety issue is very important thing. So, how do you address and managing key toxicities associated ADC and some TKI? And I'd like to ask some the sharing your experience in this field and especially in the toxicities.
We know ADC is a topic, I think side effect is ILD. So I always suggest that the patient accept the practice, lung function, just encourage the patient accept the practice, focus on the lung. And I have some case, I ask the patient accept the practice, and then especially because the patient accept the clinical trial use the ADC, and at the first we observe the ILD, and I ask the patient keep a practice, and then the following 1 year the patient is okay. So ILD is a major side effect for ADC. And for TKI, it's almost we can encounter in diarrhea and rash. Diarrhea is very common, so I can suggest to the patient that so food, just on the food, no meat, just I think vegetable and noodle and others, no meat together with the drug, and then we can prescribe some drug to protect the gastric and the other Crohn, so can decrease the diarrhea. And last, the rash. Rash is the key issue. Some patient complain about the rash, so do not accept the sunshine. Do not expose it to the sun. Yeah, protect them from the sun. That's my opinion about the toxicity.
Okay.
Yeah.
How about the Utagawa? Any experience to sharing, and there is some, especially in the toxicity?
Yeah, ILD by ADC is very important. So, yeah, for my patient, I check chest X-ray every dose of ADC, and I take chest X-ray every dose, and so I give them information about ILD, for example, symptoms, cough, and yeah. And for HER2 TKIs AE, so as I mentioned, so we have so much experience of EGFR TKIs AE. So AE of HER2 TKI is related with EGFR wild inhibition. Yeah, we can manage it very easily.
So I think that the toxicity management, the issue is whether this toxicity is expected or not. So, and there's the diarrhea or rash is so troublesome to the patient, and it is some kind of burden for our patient. However, some expectation. How about the ILD pneumonitis is unexpected. So we cannot expect the ILDs occurred or not. So I think there's some proactive management in the diarrhea or some rash in the related TKI is very important. The management in our patient. Yeah.
Okay, let's focus on the question, prospective on diagnostic testing and identify the HER2 mutation. I just now, Professor Kim, just two cases. The first case is HER2 mutation plus the TP53 mutation, right? And the second case is HER2 mutation plus the HER2 amplification. So we know ADC is sensitive to the HER2 mutation and amplification. Oh no, HER2 expression, overexpression, not sensitive to the HER2 amplification. But TKI is just sensitive to the HER2 mutation, not sensitive to the HER2 overexpression. So I think what do you think about the biomarker testing, especially co-mutation with the KRAS or TP53? If the patient has the TP53 mutation, what do you suggest the patient accept ADC or TKI or combine it together?
So it is very important question. So in the era of the NGS testings, we accidentally found that a lot of co-mutation they're accompanied with some driver mutation. So I think that regarding the TP53 is very poor prognostic factors if the concurrently others the driver mutation. This is some very similar the way similar cases in the patient with the HER2-mutated lung cancer patient. However, the TP53 is not predictive factors. It is some kind of the prognostic factor. So the presence of the TP53 cannot affect which regimen is more preferred regimen between the ADC and TKI. So I think that some TP53 is just some prognostic factor, is not predictive factor, and this cannot be affected the decision making in our patient.
Okay, so that's fine. And so next question, what support and information do patients or caregivers need to better understand the result? If the patient gets the NGS result?
Yeah, this is a very good question. So yeah, I informed them the result of a genetic alteration testing. So for example, if they have a EGFR mutation, so EGFR TKI is very good treatment, and there are some adverse event by EGFR TKI. So yeah, I inform them treatment and adverse event and prognosis. Yeah, I usually do them.
Okay. So we just focus on the perspective on individual. Okay. How do we best support the patient and their caregivers through the journey? especially consideration for the Asian population. What's your suggestion, Professor Kim?
Yeah, so I think there's some, based on the data, so there was no big differences in terms of adverse event or efficacies, luckily in the HER2, the mutation, the landscape. So, however, I think there's it is very important to the reassurance about the toxicity management in this our patient, especially treated with TKI and the ADC. So, for example, regarding the trastuzumab deruxtecan, this is some very risky. One of the critical issues about the TDXD is ILD and the pneumonitis. And the patient have symptoms like that, dyspnea, only ejection, or some kind of the dry cough, or some the dyspnea, so a little dyspnea. So I think there's some the catch up in the initial the development phases is very important issue. So I think there's regarding the adverse event or some related adjudicated event, the education is very important to the caregiver and the patient itself. So it could be early detection and early management is very important to save our patient lives.
Yeah, that's important. What do you have a suggestion, Professor Utagawa?
Yeah, so I'm just a medical oncologist. So patient needs palliative care and psychological care. So I establish and make a team for patients. So including nurse and other doctors and other member of their life. So yeah, I think making a team is very important.
Okay, thank you. And the last 2 minutes, I will give us some key information and the key takeaway. So ask after 1.5 hour, we just talk about the HER2 mutation. So this information is very important to take away. The first is HER2 mutation lead to poor prognosis in non-small cell lung cancer. So therefore, timely identification is a key issue in guiding anti-HER2 target therapy. So we need to detect and test. The second is current treatment, including the first line of platinum-based chemotherapy plus the immunotherapy. And for those patients with progressive disease, TDSD, ADC is recommended, and Cevabertini and Zongtini are promising the TKI with approval. So in the future, if the TKI is available, we can suggest that the patient accept the TKI treatment. The third is targeted approaches with the TKI. SOHO being clinical trial and the ADC destined lung clinical trial are being investigated in the frontier setting. So right now, the first line, I think, should be positive result in the future. But we have no result right now. The last ongoing opportunity, including the optimization of ADC structure design, novel combination approaches such as ADC plus the immunotherapy, or TKI plus the ADC, and sequence strategies for ADC and TKI. And the key issue, resistant mechanism to anti-HER2 targeted therapy, we need to explore. We need to clinical trial on this HER2 mutated patient. I hope next year we can get new result, new data about this. Thank you for Professor Keynes. Thank you for Professor Utagawa, and thank you for the group. Thank you.